Good afternoon. I'm Kae Jack TAY from Singapore General Hospital. I would like to thank Dr. Peter Chew and the organizing committee of the CUHK Urology Symposium for inviting me to give this talk on prostate focal cryotherapy. Focal therapy for prostate cancer aims to eliminate the cancer focus, yet preserve uninvolved tissue in an attempt to maintain a patient's quality of life. Cryoablation refers to the removal of heat from an area in order to disrupt the cellular architecture through ice crystal formation from repeated freezing and thawing. The modern approach utilizes the Joule-Thomson effect, where rapid decompression of argon gas results in lowering of temperatures. In living tissue, negative 20 degrees Celsius is considered lethal. Compared to the old days, where liquid nitrogen was used, this technology now allows for miniaturization of cryoprobes so that they are highly maneuverable. These cryoprobes are usually placed transperineally, giving excellent access to any area of the prostate. Specifically, anterior prostate cancers, such as this one indicated with the red arrow, are sometimes difficult to diagnose and reach due to their position. But these can often be easily ablated transperineally. Here, 4 cryoprobes have been placed in the anterior prostate, shown in the upper 2 figures. The lower left figure shows an expanding ice ball, and the lower right panel shows that the anterior apical temperature is at the lethal range, while the external sphincter and the neurovascular bundles remain at body temperature. I think that anterior lesions are particularly suited for focal cryotherapy for this reason, and there has been increasing interest in treating anterior lesions with focal cryotherapy internationally. Before we do proceed further, I would like to revisit the guidelines. Most major guidelines state that ablative therapies for prostate cancer remain experimental and should only be performed within a clinical trial or a well-designed prospective cohort study. We started our program in Singapore initially as a phase 2 clinical trial in 2019. And after treating the first 30 patients, we have since expanded this to a prospective observational study. Based on expert consensus, we included patients with a maximum of 2 lesions, less than 1.5 ml, maximum of Gleason grade of 4+4, and a maximum PSA of 15. We also mandated a repeat MRI and biopsy at 12 months after treatment. Among the first 30 patients, we did not encounter any serious complications. The only ones that required intervention were those that went into retention and required catheterization. All other side effects encountered were mild and resolved within 1 to 2 weeks. This is a case of a 72-year-old gentleman with a PSA of 8.4. MRI showed a right posterior peripheral zone lesion and another in the central posterior zone. We performed a fusion-targeted biopsy, followed by a concomitant saturation biopsy. The targeted biopsy showed Gleason 3+3 cancer in the target area, but the saturation biopsy showed more cancer, an additional core of Gleason 3+4 cancer near the target area, and a new 3+3 cancer on the opposite side. Here is a schema depicting how the configuration of the lesion was based on combined MRI and biopsy information. It is interesting to me how the goal of focal therapy has evolved over the years. At first, we wanted to eradicate all cancer. Then, as evidence showed how effective active surveillance was, the goal was then to eradicate only clinically significant cancer. Most recently, the goal has been to completely ablate cancer and to delay or altogether avoid radical therapy, perhaps indefinitely, through treatment, retreatment, and surveillance. Of course, we will need more evidence to determine if this could become a mainstream approach, but it is already becoming something patients are asking for in order to maintain quality of life. It's also important to recognize, however, that only a certain subset of men are actually suitable for focal therapy. And that is why we have been extremely cautious in selecting our candidates with targeted and saturation biopsies to better define their disease. Here is our OT setup. The patient is placed in a lithotomy position, and we have prepared the urethral warming catheter to protect the urethra during treatment, the biplanar ultrasound probe and machine, and the cryogenerator. Before we begin the procedure, we test the cryoprobes to make sure that there is no gas leakage that could cause an embolism, and to make sure the freezing and thawing functions are working well. Here, we're inserting the first cryoprobe. We check it in the transverse and sagittal views, and then we insert the second cryoprobe. Both of these are in the right posterior peripheral zone. Additionally, we are going to freeze the lesion that we saw in the left posterior peripheral zone. This one is more medial, more central, and was detected on the saturation biopsy. And here's the projected ice ball that would form in the sagittal view. Next, we place temperature probes, the first one in the right neurovascular bundle, the second one in the non-villar fascia. And here's the third one that we are placing at the external sphincter. It really is in the pelvic floor that's just posterior to where the urethra is. This is how it looks prior to starting the freeze. You may have noted that one of our probes, the one on the left, the posterior zone, is pretty posterior. So we've decided to hydrodissect the non-villar fascia to provide some additional space. Then we perform a cystoscopy to check that the urethra is intact, and we place a urethral warming catheter over a supersieve guide wire. This is maintained at a 42 degrees Celsius to keep the urethra warm and protected so that the mucosa remains intact. But because of the need to protect and warm the urethra, periurethral tumors within 5 millimeters of the urethra usually do not respond well to treatment. I usually avoid these. Here, we can see the first ice ball forming. This is closely monitored in the transverse and sagittal views. As the ice ball reaches the second probe, we activate that as well. It is important to remember that the edge of the ice ball is at 0 degrees C, and the lethal temperature is usually at about 3 to 5 millimeters behind it. But by using the ice edge and visualizing it on the ultrasound in 3 dimensions, we can estimate the margin of treatment. Here you can see that as the ice ball approaches the temperature probe in the non-villar fascia, that temperature is at 7 degrees Celsius. You notice that the right neurovascular bundle is also at 3 degrees Celsius because that's pretty near where the tumor is. Here we can see that the cryoablated zone, as seen on the ultrasound, matches up with our idea or concept of where the tumor is based on ultrasound, biopsy, and the MRI. And here we are freezing the left posterior peripheral zone lesion. After completing one freeze-thaw cycle, the freeze is approximately 6 minutes and the thaw about 5 to 6 minutes, we perform a second cycle. After 2 freeze-thaw cycles are completed, then the treatment is considered to be complete. The history of focal therapy remains short, and it is difficult to assess the oncological outcomes. In my opinion, the best way to define the short-term outcomes is with imaging and repeat biopsy. Recurrences can be defined as infield or outfield. Infield recurrences are those that occur in the treated area and may represent incomplete ablation or technical failure. Outfield recurrence could be due to missed cancer not detected at initial biopsy or new cancer that has arisen. In a review of about 16 focal therapy cohorts with mandated rebiopsy 6 to 12 months after surgery, the rates of having clinically significant cancer, or CSD, infield or outfield is at about 10% at median. In my experience, some recurrences have been marginal rather than truly infield. This figure is an example of laser ablation, which is highly targeted and very effective, where a lethal temperature was reached in the target zone, and a defect was seen on the post-treatment MRI in the left lower panel. However, at prostatectomy, viable tumor is still seen around the treated area, indicating that perhaps estimation of the margins was not as good. Priester et al. Have shown very nicely that MRI often underestimates tumor volume, sometimes by as much as 10 millimeters. And this may be the reason why marginal recurrences occur, especially if we base our ablation heavily on the imaging. In our study correlating whole mount radical prostatectomy specimens with MRI, we found that a 5 millimeter margin around the MRI lesion could treat almost all of the high-grade components of the lesion, potentially leaving some low-grade cancer at the margin. And this has important implications in how we visualize the ice ball in 3 dimensions to ensure adequate coverage of the tumor. Back to our case. After cryoablation, this gentleman's PSA went down. 1 year later, he had a repeat MRI, which shows the ablated area in the right peripheral zone. Repeat fusion and saturation biopsy shows a small volume Gleason 3+3 cancer in 2 cores. This was outfield of the treated area. So he has gone back on active surveillance. To summarize, I think that focal cryotherapy is a good technique in focal therapy for selected patients. For those who are hoping to start a program, I would advise to make sure that one is familiar with transperineal techniques. Many of us are. Specialized equipment is needed, so do make sure that you have the necessary regulatory approvals, the cryogenerator, cryoprobes, urethral warmer. I think it's best to start with anterior tumors, away from the urethra. And finally, refining your technique and close monitoring during the ablation so that we can avoid critical structures while achieving complete ablation of the cancer. Thank you very much for your time. I'll be happy to take any questions.